Good afternoon. Welcome again to the members of the press who are on the line and in the room, and thank you for taking the time to listen to today's briefing by the Pan American Health Organization. Aside from what individuals, families, and communities can do to control this outbreak, PAHO is working very hard to ensure equitable access to pandemic vaccines when they become available. Ongoing work by WHO has identified up to 24 vaccine manufacturers around the world who are committed and ready to proceed with the manufacture of pandemic vaccine when candidate vaccine strains become available. The candidate vaccine strains are currently being made by WHO collaborating centers around the world. The procedures used to produce these candidate vaccine strains ensure that they're the safest, most reliable candidates. And the information we have at hand indicates to us that these strains will be available by the end of this month. Based on this background information, we can then predict when vaccine will become available in national vaccination programs, and we estimate that to be 4 to 6 months. Of concern to us, however, is that some of this supply that will become available is tied up even before it's produced. There are a number of pre-production contracts that companies have made with certain countries. So PAHO is concerned about this, and we're working hard to ensure that vaccine supply is available for all developing countries. To that end, the Director General of WHO is taking time next week to meet with as many vaccine manufacturers as possible during the World Health Assembly in Geneva to discuss these issues of access and availability. Her message will echo PAHO's longstanding commitment to ensuring access to vaccines, including the pandemic vaccine. As we speak, PAHO is working with countries on their vaccine deployment plans so that when vaccine becomes available, they're way ahead of the game in the work that goes into preparation and training. There have been a lot of questions about the origin of the virus causing this outbreak. A reputable scientist notified WHO last Saturday that he intended to publish his findings suggesting that the origin of the virus causing the outbreak was indeed a virus that had originated in a laboratory, and this raises some obvious implications. He conducted his research using the genetic sequencing data that has been made available by public access in the interest of complete transparency. Upon notification of this scientist's intent, WHO immediately contacted teams of experts from its collaborating centers around the world and requested them urgently to carefully evaluate this study and the results produced from this research. Within a matter of days, they concluded that the virus is a naturally occurring virus which did not originate from a laboratory. Without going into the details of the amount of work that went into putting together a rather substantial amount of scientific evidence which was able to refute the conclusions of the scientists, I think this is an example of intense work which illustrates how people are working in a culture of information sharing and complete transparency. And they're doing so in order to provide the best response to the outbreak. It also highlights the need to continue monitoring the evolution of this situation and to question certain assumptions that we may take for granted on a daily basis. But at the end of the day, when we are questioned, we're able to respond in an appropriate fashion with the best science available. And to that end, we will have the best evidence to explain what we are seeing. So again, as I've repeatedly said over and over, let's remain focused on being as prepared as possible. And with that, I'll take any questions that any of you may have. Thank you very much. But I think your question raising the adverse event issue of 1976 is an excellent question, because as many of you on the line or in this room can remember, the frightening scare of millions of people being vaccinated, and then the unexpected occurrence of Guillain-Barré syndrome. And for those of you that don't know what Guillain-Barré syndrome is, it's a condition that causes paralysis of the body. And in fact, those of you who have worked in the polio eradication initiative knows that this is one of the differential diagnoses when you see a child with acute flaccid paralysis. So it can be quite serious. And so with that background information, I should state a few things that will help us better understand the risk. With the swine flu, as I recall, for every 1,000,000 doses administered, there were some 8 or so cases of Guillain-Barré syndrome, which is a very high rate, unacceptable. As opposed to what we see normally in the population, this means that we, without vaccination, expect this syndrome to occur because there are multiple causes. Most commonly, a cause is after an acute viral infection. So we expect to see a certain rate in the population based on that knowledge, and when we see a higher rate, then we begin to wonder, well, is there something causing it? And that's indeed the process that evolved at that time with the 1976 problem. So they were able to do the studies to show it was a significantly higher rate, and then demonstrated it was associated with the vaccine. So since that time, we've had years and years of experience with the use of seasonal vaccine. Some people question that risk associated with Guillain-Barré. Some experts believe there's no risk, but if we follow those rates, they remain very low and independent of the seasonal vaccine use, so thereby shows us that there's no, or if there is a risk, it's very, very, very small. I think that answers your question. You had one question about the deaths as well.
The fact that it doesn't seem to concern many people in America. I mean, they don't seem to be preoccupied by it.
Yeah, the 5 deaths. I think you, as a reporter, and as we follow this, we are seeing less information coming out over the last week, so that might imply that there's less concern. I do know, however, that the Commissioner of Health of New York City, Dr. Tom Frieden, who today, by the way, was announced as the new director of the CDC, he, with the mayor, decided to close 3 schools just, I think it was yesterday, if not the day before yesterday. But they decided recently to close 3 schools, showing to me that the public health officials remain on high alert and are quite concerned. Perhaps the measurement of your finding might be the number of articles coming out in the press. And we just were speaking to reporters yesterday, and this came up, and we feel that the role of the press is critical in keeping the alert and following and monitoring what evolves with this infection.
Thank you, Dr. Andrus. We had, I think, 4 people on the line in the English room. Are any of those phone questions available now? Okay, and if not, we will go ahead with a question from Caracas, the Diario Últimas Noticias. And she asks, what is the most trustworthy diagnostic method to determine the presence of influenza A H1N1 virus. She says, are immunofluorescence and traditional PCR methods the most useful in this case?
That is a very good question, and what I know about the testing, immunofluorescence in particular, is that it has a lower sensitivity. And actually, the PCR that we are using has a much higher sensitivity and is producing better results. The question relates to the gold standard of trying to identify the cause of a constellation of syndromes that we know we refer to as the influenza-like presentation. And so to be sure that somebody that's coughing has a high fever, it's caused by this particular virus, generally speaking, the gold standard in infectious diseases is actually isolating the virus. There is no doubt after you isolated the virus, or I shouldn't say no 100% of the time, but it's be very unlikely that you're making a misdiagnosis. And then the PCR is actually a very, very good test that we're finding works quite well. And in the case of Mexico, when that test is used to identify a probable case, meaning it's not yet confirmed, but it's a probable case, that test tells us that it's influenza A. And doing an analysis of those data, that influenza A information gives us a predictability of about 99.9% to show that it's actually the virus influenza A H1N1. Again, evidence to show how good the test is. I think the challenge that maybe the reporter is alluding to as well is that we're now seeing more asymptomatic cases, and certainly those cases are not being captured or identified if you have milder symptoms.
Okay, thanks. Then we have a question from Gregorio Arias Lopez in Guadalajara, who says, a person who is diagnosed with influenza, seasonal influenza, or AH1N1, or even influenza B, can receive treatment with antivirals. How long is that person still a transmitter of the virus? In other words, how long does he have to stay home before he can not be infectious anymore, or go to school and go to work, after he's had antiviral treatment?
Well, I think I would say, and I'm going to tease this out layer by layer, but I would say overall, because there are other factors involved, that it's just to be on the safe side of things, to stay home from school or work until you feel you're recovered. So having said that, we know that if antivirals are given within the first 48 hours of symptoms, they're actually very, very effective. If it's the right class of antivirals and the virus is sensitive to that particular agent. And we know with this virus, the virus is sensitive to oseltamivir, and that's the medication that WHO and PAHO have been recommending, and actually the medication that we've been dispensing from our stockpile in Geneva as well as in Panama. So I made that first recommendation knowing that in public health it's important to keep messages simple and effective. So there may be variations of when the person received the antiviral medication. Let's say the day, rather than getting the medication within the first 48 hours, there still may be some benefit on day 3, but the medication may not be as effective. So I think the good rule of thumb is to stay home until you feel well. There will be some variation on the effectiveness of the medication depending on how early in the illness you give it. And the final point about once you start taking the medication, if it is in the right period after onset of symptoms, you probably are not infectious after a few days, but that data I don't have in hand, and I can't say with absolute certainty. So I think the safe thing to do is stay home until you feel well.
Okay, thanks, Dr. Andrus. Then we have a question which you answered in part, I think, but he's asking a little bit more, from La Prensa in Honduras, who was asking about the theory of the Australian scientist Adrian Gibbs that the virus was the product of a human error in a laboratory. What she's asking about is, how did we really determine that he was mistaken?
That's a great question, and I'll try to frame my response so that it's clear. The observation of this scientist noted that the virus he was looking at, based on the genome, the data he had available, he felt that there was evidence of increased lysine residues. Lysine is an amino acid, and it's a common amino acid that you see in organisms like viruses. And he felt that the occurrence of or the frequency of those residues suggested that it might be a laboratory origin virus. In addition, there were some other interesting findings that the virus tended to mutate, but I think mostly due to the presence of those residues. In molecular biology, there's a term used called the phylogenetic tree, and I think if we just sort of look at it like our own family trees and we try to trace our ancestors back, there are always those branches of uncles or cousins out there on a limb that might be different than what you see in your family. And that was another point he noted, that this virus tended to be so far out on a limb, using that analogy, that it suggested that it was more a laboratory origin virus than a naturally occurring. So when the group of experts came together and they looked at all this data and analysis in more detail, they all came to conclude through consensus that although he had noted that, they had also were able to show that this was consistent with naturally occurring virus. Another piece of evidence that was used was the rate of, I believe it was reproduction. It replicated faster. And when you use a term like faster, you're comparing to something. And what they decided to do was look at what he compared to, and it turned out to be a part of the genome that apparently replicates at a slow rate. So if you compare anything against that, it will appear faster. So I think, in summary, all of those 3 or 4 things that were critically looked at was the basis of the evidence that allowed them to say, we disagree. This is a virus from a naturally occurring virus. So I hope that answers the question.
I think it does. And while we're on the virus, we have another question from Fernando Guance, who says, the actual virus that's producing this pandemic is A H1N1. And isn't this an old name for a new virus that causes confusion? And his question is really, in the structure of the 8 genome segments of the virus, do we know in which segments the recombination of the virus was produced?
Boy, that's a great question. I unfortunately don't have the answer to that in the detail I think he's looking for, so I'd be happy to get back if we could take note, and I'd be happy to respond. But it is a great question. I think, getting back to the start of the question, I could shed some light on the issue there, that the taxonomy or the nomenclature used to name these viruses uses terms like A to denote the type of influenza virus, and he mentioned that there's A, there's also B, and that that type then has subtypes. And the subtypes are H1N1, and he noted also that there are a number of different H subtypes, and similarly a number of N subtypes. So you can have permutations of the combinations of these, and that's indeed what happens. And then there are strains, and the strains are numbered. But it really goes into a lot of detail to be able to determine exactly the characteristics of a certain strain that caused a certain outbreak.
Okay, and then sticking on H1N1, which seems to be a popular subject today, Doris Gomorra from El Universal in Mexico says, do we have detailed information about the mutation of H1N1, and if we could clarify details of the genetic material of H1N1, like do the genes really come from Asian, European swine, North American swine? Do we have detailed information yet about the mutation that has been found reportedly in Canada, Mexico, and the U.S., and if this is significant at all or part of normal activity?
It's a good question, and it's work in progress. The information we have allows the scientists to describe in detail the strain and the subtype that I mentioned. The virus mutates at a certain rate, and it happens to be relatively frequently. I can't pin a number on it, but I think that over time the virus mutates, and that's what we call drift, genetic drift. So a virus today may evolve with some modifications being the same virus over the next year, but it's drifted a little bit. It's not exactly the same, but it still remains close, and that's what's called drift. And I believe that's what the reporter is referring to. There's another situation, though, however, that's called shift, and that's where pieces, relatively large pieces of DNA are recombined to form a completely new virus, and that's what happened in this situation, this new H1N1 virus.
Now we have a question about PCR. Is there really a difference between the traditional PCR test and the real-time PCR, and are PAHO and WHO supplying real-time PCR testing kits to the countries?
Well, I know the answer to that second part of the question. Yes, we are providing real-time PCR, largely due to the incredible work done by CDC to produce the test as well as the reagents that go along with the test since the first identification of that virus. So just about all our countries should have those supplies. The difference is, I'm not a virologist. I'm looking around the room if we have a virologist in the room that would be able to determine what the old PCR test was, and if it's different from the real time that that I know of. Again, we can get back to that person.
Okay, and then we had one last question from Venezuela, which said that up to date in Venezuela, they've evaluated 159 suspicious or possible cases, and all have been negative, but using traditional PCR and immunofluorescence. Is it possible that any of these could have been false positives or false negatives, and that this wouldn't have been caught in the diagnosis using immunofluorescence or traditional PCR methods?
It's an excellent question. I know with immunofluorescence that the sensitivity is lower, and maybe as low as 60%. So what that means is if you know you have 100 infections, what we call true infections, and then you apply that test, you would identify 60 out of the 100. So 40 would be falsely classified as negative. And with immunofluorescence, that indeed is a problem. With PCR, however, that problem is greatly alleviated by the sensitivity of the test being much, much higher. Again, at the moment, I'm not aware of the older types of PCR and how they're different from what we're using today as real-time PCR, which is the method that we're dispensing to countries. So I'll need to get back on that.
Okay, thanks, Dr. Andrus. I think we've taken care of all the mail-in and illuminated questions. Are there any other questions from people in the room at this stage? Okay, Armando, please.
Doctor, if this was naturally occurring, this virus, was that due to the extremely poor sanitary conditions where this virus may have been created? There has been many people pointing out that different places in Perote and Veracruz, in the state of Veracruz in Mexico, as the main or the focus of this origination. Do you give any credence to that? And would the extremely poor sanitary conditions will be prone for something like that to be created naturally?
You raise a very interesting question that I think allows me to sort of take a step back and maybe share some information that will provide or shed some light on your question. In public health and epidemiology, we think of the environment, we think of the hosts, and we think of factors related to the agent that combined together result in what you see in terms of the occurrence of disease or a condition of health. In the case of the environment, we definitely know that when, and this was very much a concern with bird flu, where in certain communities, families may live in situations where actually their farm animals are living with them, maybe in the same house even, so that exposure offers a greater likelihood of viruses jumping from one species to the other. And that's a well-known phenomenon. And to the extent that happened in Veracruz or in the other place you mentioned, that's always a possibility. There are other factors, however, related to the virus itself and the likelihood of it being receptive to those kinds of environmental forces to do certain things. And then, of course, the host being the individual that gets infected. If the person has chronic heart disease, then that person has a likelihood of more severe form of disease. If the person is malnourished, they will have increased likelihood of other complications and so on. So I think thinking of it from those three different angles helps me address your question. I think most likely, though, is the environmental situation where there's more contact and more close contact in a confined situation where you see in some cultures. Thank you.